share my slides now, or should we wait?
No, I'll introduce you, sir. Then
Okay.
I'll hand over
Okay,
the
great.
program. So, good morning, good evening to viewers across the globe, and welcome everybody to today's Pure program. So, we conduct these kind of talks with experts where they share their surgical experience with us. Today, we are going to discuss about the RIRS, the intrarenal pressures, and also the dusting techniques. So RIRS, or the ureteroscopy, is one of the most commonly performed procedures by the urologist across the globe. It has become very common. The only concern we face is the risk of sepsis, which is directly related to the rise in the intrarenal pressure. So today we are extremely happy and privileged to have Dr. Ben Chu with us. He will be giving more insights on this regard. He has a great experience in this. He has done a lot of research in this. So now I'd like to introduce Dr. Ben Chu. He is a urologist and director of clinical research at Stone Center at Vancouver General Hospital, and he is an associate professor of urology at the University of British Columbia in Vancouver, Canada. He is also the chair of research for the Endourological Society. His main interests lie in the treatment and research of pathophysiology of kidney stone disease. His research focus includes metabolic stone disease as well as the biomaterials used in the urinary tract for ureteral stents. Current studies, he is doing research on the second messenger systems that are activated within the kidney and ureter once a stent has been placed. He is a consultant to the robotics company in the race to develop the first robotic assisted ureteroscopy, and he has worked on the development of thulium fiber laser Olympus and LithoView Elite with the Boston Scientific single-use ureteroscopes. He has authored over 105 peer-reviewed manuscripts and book chapters. He is a member of Endourological Disease Group of Excellence Edge Research Consortium and Wisconsin Quality of Life Research Consortium. We are very happy to have you today, sir. And now you can share your screen and share your thoughts with us. Thank you, sir.
Well, thank you very much for having me and that nice introduction. It's a real honor to be here. So thank you. I live in Canada, and I'm in Vancouver on the West Coast by the water. So the World Congress of Endourology was there in 2017. And as you know, the temperature there doesn't get too cold, doesn't snow that much, but it actually has snowed this year. Currently, I'm in actually Washington, D.C., just visiting some families. So thank you for this invitation. I want to introduce Naeem Bojani, who's also been very integral in working on this research that we've been doing for the intrarenal pressure. And also I want to talk about the new LithoView Elite ureteroscope, which is a ureteroscope which senses intrarenal pressure. It's the new single-use scope. And then I also want to talk a little bit about the thulium fiber laser, as well as the Helium YAG with the Moses technology. So those are kind of the three things we'll touch on. And I do work with some companies, namely, of course, Boston Scientific in helping develop the LithoView Elite, Olympus in helping develop the Saltive thulium fiber laser, and then some other companies here as well too. And Johnson & Johnson is the one for the robotic one, but I think the Olympus and Boston Scientific will be the main ones that come into play today. So as you mentioned already, sepsis post-ureteroscopy is a problem that we have. And Naeem and I did a meta-analysis looking at about 13 articles with just over 5,500 patients. And what we found was that it was quite variable. What they reported on ranged between 0.2 to 17.8%. But when you pool all the patients together, it's about 5%, and that's about 1 in 20 patients. Although 5% doesn't sound that much, 1 in 20 patients does definitely sound a lot more. And the 6 things that we found that were very significant were having a preoperative stent, a positive preoperative urine, ischemic heart disease, diabetes, being older, or if there is a longer procedure time. So looking at other types of publications, other papers have reported between 3.9%, but when they look at the septic papers, only 7 papers reported on it. It was actually only about 0.51%, but about 6% of the total reported complications for sepsis, which is very similar to our 5%. And other review articles have found very similar to what we found, but in addition, they found female gender, neurogenic bladder, and having a high body mass index or being overweight was also a factor for getting sepsis afterwards as well too. So I think those are just things to keep in mind. If you have any of those sort of 6 to 9 things that these people might need some more antibiotics, post-ureteroscopy, then we took a data set. This is a data set of about 104,000 ureteroscopies in the US. And this has all of the people who are working and have a insurance plan with their employer. And we wanted to look at the sepsis rate here by ICD-9 and ICD-10 codes. So it was about 105,000 ureteroscopies, and we found that the sepsis rate was 5.48%. So very similar to what we had in our 5%. Most of them had it within about 1.88 days. So nice to verify what we had in 104,000 ureteroscopies. And then you looked at the sepsis versus the non-sepsis. And obviously there was more inpatient visits, significantly more ICU visits, and they also had a longer length of stay. And the cost, so if you took a regular ureteroscopy in the United States, cost about 17,000 US dollars. I think probably India is more like Canada, where we look at that number and say that's a little bit high, but nevertheless, that's what it costs in the United States. But if you get septic, the number jumps up to 49,000 versus 17,000. And then if you separate out the just regular sepsis versus the very severe sepsis, and there's ICD-9 criteria for this, the severe sepsis cohort actually had a much higher inpatient stay. We're utilizing the ICU 66% of the time versus only 24% of the time, and had a much longer length of stay as an inpatient. But not only that, the costs jumped from 43,000 up to almost $69,000. So the cost of sepsis is actually very, very important, and I think difficult for our medical systems. And then mortality even makes it worse as well too. Certainly, if you get septic, there is definitely a higher cost of healthcare system and a higher chance of mortality if you get septic. So what are the things that can happen? So after you place a stent in someone, either for sepsis or for non-sepsis, for instance, if you are pre-stenting them, how long should you wait? David Lifshitz did a retrospective study and looked at the times of when they put the stent in and then when they got the risk factors. And essentially with them, it was about 4 weeks. So if you do put a stent in, doing the ureteroscopy before the end of 4 weeks will be helpful in reducing the amount of sepsis. And Naeem Bojani took that same data set of 104,000 and actually found that the patients who were pre-stented, they looked at between 0 to 15 days, 2 weeks to 4 weeks, 1 month to 2 months, and then greater than 2 months. And what they actually found was that the best time was less than 2 weeks. Does that mean 1 day or 2 days? They couldn't tell that, but the best time was in this time group here between 0 to 15 days, as opposed to 2 to 4 weeks. So if you do put a stent in for someone who's septic, you definitely want to put it in. You definitely want to get their ureteroscopy done within 2 to 4 weeks of the stent placement. Now, one of the things, as you mentioned too, is intrarenal pressure, and I think this has been a bit of a hot topic of research. And I think temperature is also a big one that we need to get into as well too, and that's more for renal damage, not necessarily for sepsis. But I think certainly intrarenal pressure is something that plays a role. And what we do know, and the two things that we can control, is what type of irrigation method we use, and whether we use a ureteral access sheath. So the types of irrigation, obviously, we can use gravity, we can use pressure irrigation, we can use hand pumps, we can use syringes, all these various things. And it's also impacted by what we have inside of our channel. Is there a laser fiber? Is there a basket? And in terms of the access sheath, what size do we use? What length do we use? Where do we place it? And we did a little bit of some work on that, and I'll show you some of that information. Now, what we don't know is what is the impact of pilovenous and pilotubular backflow. We suspect that there's something to do with pain. Um, with having that increased pressure, does the patient just get more pain? And is that from a one peak pressure that goes above one level, or is it sustained pressure over a very long time? We don't know these things. And in terms of infectious complications, what is that cutoff? What intrarenal pressure will cause this, and in which patients? So I think we really need to sort of study these, and we don't really know how to answer these questions. And before all this, it was very difficult to measure intrarenal pressure. We had to put out special guide wires. You had to do it in patients with nephrostomy tubes. Now, this is the next generation LithoVue Elite single-use digital ureteroscope. It comes with a separate box. And this scope is very similar in size and shape to the previous original LithoVue, but it is actually quite different in terms of its internal mechanics. So one of the things is the cables are different. They're not quite as stiff as the other one. The outer part is still the same. Still has a chip. However, the chip is actually, and the deflection is still the same as the first one. It's very good. We did a study of this on the Edge Consortium, and we compared it to a Stort's reusable, brand new digital ureteroscope. And the single use one, obviously because it's new every time, maintained its deflection. You can see it goes all the way around. Versus over time, our Storts did start to lose deflection a little bit. But I'd like to say that the main thing about this one, besides the fact that it measured intrarenal pressure, is that this is looking through the scope, is that the resolution is much better than the original LithoVue. In fact, I would say it's starting to really, and the color rendition is amazing. It's really starting to render and get very close to what you would traditionally consider the visualization of what you would get in the reusable digital scope. So even though this is single use, it's quite good. We took it to the lab with one of our engineers we work with, Dr. Nabil Shalabi, and he actually tested it inside of a pressure container with all these various things that I don't even pretend to understand. It basically measured how accurate the pressure measurements are. And you can see here, it's 0.96, 0.9967. So it's very accurate at actually measuring the pressures. So we put it inside of a pig, and this is before it was allowed for humans last summer. And we used 80 centimeters of gravity, and you can see the pressure on the side over here. Then we used a pressure bag, which went up to about 80 or so millimeters of mercury, 90 something actually. And then we switched over to a self-filling syringe, the self-filling action pump. And then we were pushing it inside of a calyx. We even had a laser fiber in to simulate what you would be doing. And it was up to about 140 or so millimeters of mercury. Then the last one we did was we actually used just a manual syringe and just tried to push really as hard as we could. You know, probably a little bit clinically not correct because, you know, we were really trying to see how high up we could get this. And this went up to about 200 millimeters of mercury. And remember, this is inside of a pig, which is slightly different from inside of a human. But we were just able to show that with these different types of irrigation methods, that they were really quite different. And that's one of the things that we can do is change our irrigation methods. So what is the clinical significance of this? You know, now at least we have a tool. So we took that further and went inside of a pig and looked and saw, is the ureteral access sheath, which is one of the other things that we can change. You remember the irrigation method or the ureteral access sheath. Is it effective in lowering intrarenal pressure? And I think we already know that. I think there's been several studies showing that that is the case. This is Professor Traxler, Dr. Julia Rosette from the CROWS, from the Endo Society group, looking at a very large group of about 11,000 patients to see whether or not there was a difference. And essentially the septic rate was actually about a third. It was only 4% in the ureteral access sheath group and about 15% in the non-ureteral access sheath group. So certainly we've shown that in a large data set that it does do that. In patients, in a smaller study, however, with Bhaskar Somani, reviewing their own hospital, there was only 68 procedures. They found that the sepsis rate was no different and was about 11%. So a little bit, and that was for big stones greater than 2 centimeters. So really, you know, what we do know, and I didn't show the literature for this, is that in uncomplicated patients, that don't have an infection with that particular stone, so they weren't infected and came in and required a pre-stent, that they don't need pre-op oral antibiotics, just the one dose at the time of ureteroscopy. So this is what we do: one IV shot, intravenous shot of cefazolin right at the time of ureteroscopy, and that's sufficient. If they do have episodes of sepsis, it may not be a bad idea to give them a few days of some preoperative antibiotics and some postoperative days as well too. And in terms of the ureteral access sheath, I'll show you some other data we did in the pig here, but these are just to sort of evaluate some of the things that we talked about for the risk factors. And perhaps you can treat these on a case-by-case basis and think that some of these patients may require more antibiotics than just the one dose that you would normally get them. But what we really need to do is to correlate this with intrarenal pressure. And now we have this ureteroscope where we can measure the pressure in every case. So what we did was Naeem and I took the LithoVue Elite, and then we took different size access sheaths. We took the 1113 and the 1214, and what we did, and the 911 too. And what we did was we actually put them either in the renal pelvis, below the ureteropelvic junction, or in the distal ureter. And we did the different sizes. And we did all the different types of irrigation methods to sort of show you what we did. So we used an 1113 ureteral access sheath. We put it just below the UPJ with no laser, with the laser. This is inside the renal pelvis with no laser. This is inside the renal pelvis with the laser, and then in the distal ureter. And then we just did it with no irrigation, a gravity bag at 80 centimeters of water, a pressure bag at 150 centimeters, the self-action pump syringe, the manual syringe, or the 300 millimeter bag of mercury. There's a lot of data here because we've used the 1214 as well as the 1315. So sorry, those are the three we used: the 1113, 1214, and 1315. And let me just summarize for you what we found. We found that the 1113 actually did not provide enough reduction in pressure that was significant. The 1113 was just a little bit lower than having no sheath, but this was not statistically significant. You needed at least a 1214 and the larger 1315, which I think is really quite large and difficult to get up in patients, particularly if they haven't received preoperative alpha blockers. You need at least a 1214 ureteral access sheath to provide intrarenal pressure. In terms of the location, placing it right inside the renal pelvis generated the lowest intrarenal pressure. So that was the best place. And the next best place was actually putting it in the distal ureter. We found that the fluid was just leaking out of the access sheath. It's nice to see that. The ureteropelvic junction, or just below it, actually created the highest pressure. And I think what happens when we hypothesized why this was happening, because this is actually where I used to place my access sheath, and I find it hard to get inside the renal pelvis. Sometimes it's very tight UPJ. Sometimes it's a very dangerous area to put it in. So I usually put it right below the renal pelvis, right below the UPJ. And we think that when you put it there, it sort of just basically causes the UPJ, especially if it's tight, to basically close off, and you don't get any fluid going around the outer part of your ureteroscope. With the access sheath in the distal ureter, I think there's still some ureter that's still free that has a bit of chance to peristalse and for some of that urine or the irrigation to come through. And I think that's why the pressure is lower. And obviously, when you put it inside the renal pelvis, the fluid's just going right back out. I think the difficulty with putting it inside the renal pelvis is that sometimes it can inhibit where your scope can maneuver, so you can't get to all areas of the kidney. Now, in terms of the types of irrigation method, obviously the gravity bag was the lowest next to the just having nothing. And then the second one was the pressure bag at 150, which actually was very similar to the pressure bag at 300. Remember, putting your pressure bag at this amount of pressure, it has to go through that long tubing and then through your ureteroscope. So you're not giving 150 or 300 millimeters of mercury directly to the end of the ureteroscope. It does decrease by the time it comes out. But obviously pushing it through a manual syringe gave us the highest intrarenal pressure. When we measured inside of a calyx, it was slightly higher than inside the renal pelvis, and that makes sense because it's a smaller space, but it wasn't quite statistically significant. Placing a laser fiber in the working channel also lowered the intrarenal pressure. So this is good news for us because we often do have a laser fiber inside of our working channel, obviously. So what we do know is that we don't know what that level or what level of intrarenal pressure will trigger that pain, will trigger infection. And we basically need further clinical studies. At least now we have a tool. We think that intrarenal pressure is going to be responsible for that 1 in 20 septic episode after RIRS. That could be part of the problem. And this is the clinical use of the scope. So right now what I'm doing is I'm balancing or zeroing the scope. So we've hooked it up and you have to zero it to atmospheric pressure. So I'm placing it inside of some saline, some sterile saline on the back table, just to get this zeroed so that we can start using it so it can actually detect the pressure. And you can see, you saw in the other previous videos, and I'll show you where the reading is. So this one was taking, now it's 0, and then this is where the reading is right here. And because we're outside, it's sort of -2. It's sort of a little bit does some weird stuff until you actually get it into the system. Then once you get it into the system, it looks like this, where we're just going up the ureter. And if you touch tissue, obviously it detects that, goes up a little bit. And this is inside of a human. So we're around 26, 27, but then once you go into a calyx, it gets higher, actually. Look, it goes up to 80 because you're in a smaller space. And before, we really thought that there was just the two things we could control, the types of irrigation we use and whether or not we use a ureteral access sheath. Now we realize there's actually more things that we can do, more things that play a role in intrarenal pressure that we had no idea about. This is a 68-year-old lady. Her BMI was a little bit high. She was a little bit overweight, didn't do a lot of physical activity. She had bilateral stones. On the one side, we used a ureteral access sheath. You can see the pressure here is typically between 25 to 30 millimeters of mercury. And I'm lasering with the Helium fiber laser here, but we're somewhere between 20 to 30 millimeters of mercury. And you can see here that this visualization is actually much better than the original LithoView. Now here's the other side, smaller stone burden, so I decided not to put up a ureteral access sheath. Remember, the other side was between 20 to 30 millimeters of mercury. Now, without an access sheath, the same patient on the other side, now it's up to 100. Presumably their kidneys would be the same. It would have been nice to put up an access sheath and see what it decreased to. And actually, I've done that in patients as well, too. I've gone up just to have a look around. I said, okay, we need an access sheath, and I put up an access sheath. And certainly there's no question that a ureteral access sheath will actually bring the pressure down quite nicely. So here's the case with a patient with bilateral multiple stones. You can see in the right kidney here and in the left kidney. And when we go in here, you'll see that so we're just hooking up the ureteroscope here. Somehow my video got moved down, sorry about that. But the pressure here is about 19 to 20, and the I'm using the Helium fiber laser, which I know you use a lot in India. And it'd be great to talk. I'm going to talk next a little about lasers and settings, but I'd love to hear more about what settings you use in India, because I used to use up to about 30 to 45 watts, but with some of these reports that have come out where there have been a few sort of injured kidneys and some heat injuries, I've started to decrease my energy level with the laser just because I'm quite worried about the effect that the heat will have on there. So I like to we used to use warmed irrigation, now I use room temperature irrigation. I try to use a ureteral access sheath more just to keep the irrigation flow going. And I always have the flow on. The other thing we do now too is we don't, you can see here, we're stopping every 15 to 20 seconds. Before I used to just laser the entire time. And these were my old settings at 0.6 and 60 and 0.15 and 300. And I think this is probably a little bit too high. Now I'm trying to keep it down around 20 watts in the kidney and about 10 watts in the ureter. So this 45 watts and 36 watts is a little bit high in the kidney. I will go to the setting if I have to, but for very brief, short times, and I will laser and then stop, laser for 10 seconds and stop and let that irrigation really, really cool things down. So I think this is a really important thing to learn because I think that, and not just helium fiber laser, I think with the Helium YAG, the 120 watt laser, you can get high heat as well too, because these new lasers are so good at dusting. Um, the other thing that helium fiber has done is that, before I would sort of say 15 millimeters or bigger, I would really recommend a mini PCNL or a PCNL because I didn't think I would get them very stone free with RIRS. But now with the helium fiber and the Helium YAG with Moses, I feel like we can tackle stones that are 20 to 25 millimeters, no problems at all. But the things that I've learned here is that the kidney's like a balloon, and maybe you already knew this already, but I wasn't quite aware of all this, that you fill it, and once it gets filled, it tends to stay at that pressure. And the patient's ureteropelvic junction is important. If it's tight, and even if you have an access sheath in, unless you put it in the renal pelvis, with young males, particularly with the tight ureteropelvic junction, actually cause a very, very high renal pressure. So the EPJ is very important. And things like age and things like how, like that woman that I told you was a bit older with the high BMI versus the younger male who was quite fit, things like this we never really would have known before. And if the pressure gets really high in someone who's been septic before, I actually will take off the irrigation, put a syringe on, and actually aspirate out to get the pressure down, to sort of empty the balloon, and then we'll fill it up again. And then when the pressure starts to get high again, then I start to empty it. Be a little bit careful about doing this though, because when you do this, if you've distended or over distended any blood vessels that start to bleed, this will really impact your visualization because you get a lot more bleeding. So be careful with that. But what we do need to learn is what these cutoffs are and how long we can give these pressures for. So it's going to take a long time to figure this out, I think. But at least now we have a tool. I think that's the important part about this. And we'll figure out whether it's pain. So Naeem Bojani and I have a study where we're looking prospectively at whether patients get an infection. And then we're also looking at their pain scores, trying to correlate it with what the renal pressure was during that case. And he and I were the first to use it back in April of this year. And, people ask me, has it changed practice? And I don't know if we can say that it has yet because we don't know what those limits are. But now in other places, we have to do some without the LithoVue Elite. And I actually miss seeing the pressure now. It makes me feel a bit weird not knowing what the pressure is. So I think it's going to be one of those things where we just become used to it. And it's another tool that we rely on. So I wanted to talk a little bit about lasering techniques as well too, whether fragmenting versus dusting, but really the debate is between these two modern day lasers. And we had our EDGE Research Consortium about dusting versus laser fragmenting in the past, but that was with old type of technology. So I don't even present that data anymore. That one showed that there was no difference, but I think the dusting capabilities of these two types of lasers are incredibly different from what just the old Helium YAG is. So this is the LithoVue Elite, and we're using the Luminous, which has now been bought out by Boston Scientific, P120 with Moses. And you can see here, I'm at very low wattage, 6 watts, 0.2 and 30. This is obviously a very soft stone, but I've got Moses contact on the right and Moses distance. And remember what the Moses does is it shoots out one beam first to sort of part the waters. It kind of heats up that irrigation next to it to sort of move everything. And then the second shot comes out and actually hits the stone. Whether your distance or contact depends on the size of that first laser beam. With distance, it's actually the same size as the actual laser beam. So basically you're shooting out two. With the contact, I may be getting this mixed up, you're only shooting a half size laser versus the full size beam profile. So when you look at the dusting capability, so this is the old Homium egg on the right. This is without Moses. I'm this is actually for a course that I used to teach. It's keeping the fiber slightly off the stone. I had to, as you all know, we have to do all these little tips and tricks, manipulating the scope, painting the stone, going from the outside to the inside. Don't make big fragments because it's very hard to pop dust. Pop dusting with the old Homium Yag was really not very fun. It was very inefficient. You needed fine manipulations of the scope. When we got the thulium fiber, I was in with a very junior resident, and the one thing I found, which I really hated doing with the previous old Homium was pop dusting because I didn't find it very efficient, and you were heating up the kidney quite a bit. Now with the thulium fiber, pop dusting is amazing because the absorption of the wavelength is very close to water. This is the theory, anyways. It heats up the water and creates a lot of turbulence inside of the calyx. And when you create that, the pieces are moving around a lot more than with the old Homium Yag. And because the frequency is so rapid, 100, 200, 300, as opposed to even 80 that we can get now, or 120 with the Homium Yag, because the frequency is so high, the pop dusting capability is just so much better with the thulium fiber. The low peak power and the high frequency is just a really good recipe for dusting. If you want to make big chunks and big fragments, the thulium fiber can be challenging to do that. I found it more difficult to do it when you're working on stones in the ureter. When you want to get embedded stones out, you want that high peak power. So these are the settings that I'd like to start off with now with my thulium fiber. I only use their short, medium, and long. I really only use the short pulse for stones. For laser nucleation of the prostate, then we'll use the long pulse for the coagulation pedal, but short pulse for the cutting one. If I'm doing a upper tract urothelial carcinoma ablation, then I like to use 10 to 20 watts, like maybe 1 in 10, 2 in 10, or 1 in 20. That one I will go to medium or long pulse because then that has more coagulative ability. And this laser is great for doing upper tract urothelial carcinoma as well too. But the new setting that I've also learned about too is this 2 and 2 or 2 and 4. It sounds ridiculous, but it's actually quite amazing because when it's 200 hertz, it almost feels like you can't control the fiber. It's going everywhere. But at 4 hertz, it's very, very controllable because it's much, much slower. And in the ureter, I like to go less than 10 watts. So that's just something to keep in mind. But I want to show you some other studies, some other cases here. So these are my new settings at the 0.6 and 30. And I like to keep it at this, I call it sort of my fragmentation method. I still do like to paint the stone a little bit if I have to, if I can, just to really get this fine dust. You can see it flying off. It's just beautiful. And this is, I think, the perfect stone. It's not too hard. It's not too soft that it crumbles. For the harder stones, I will try to break them up into pieces and then do pop dusting because I think that might be a little faster. But actually, for the very hard stones, what I've been doing now is pulling out my Homium Yag, even my non-Moses Homium Yag. One of my sites only has a 30-watt Homium. It's perfect. If it's a very hard stone or very impacted, pull up the Homium Yag, 30 watts max. I usually use about 20 of it anyways, even 10. 1 in 10, break up the stone into fragments, and then put the thulium fiber in, and then pop dust. I think it's a great combination. So people ask me, which one would you buy? And I tell them, I say, well, both. But if you have a Homium Yag, I like having a thulium fiber there. If you don't have any laser, then the Homium Yag with Moses, I'll show you some Moses video here, which we recently got in the last year, is also very good at dusting. Some of the studies have shown that the thulium fiber is faster at dusting and making it into chunks versus the Homium Yag with Moses. But I show you this video here, I've just got a couple more videos to go through. So this is the very low wattage that I was telling you about. And I don't like to go over this amount inside of the ureter. So we're just in the proximal ureter here, which, and you can see the respiration. That's why you can see the kidney moving. But even these very low rates will actually work at 0.1 and 50, just 5 watts. So I know it's not going to get too hot. And I did go to medium pulse width here, but I've since have just gone back to short pulse width for here because I don't want to really create too much heat inside of the irrigation. So 0.1 and 50, and I would do this at short pulse now. But you can see the stone's not moving very well, moving very much, but it is breaking, and you do need to be in sort of closer contact with it. And I'm sort of staying in the middle because I know the kidney's moving with respiration, and obviously I don't want to do any laser damage to the ureter. And then eventually what I would like to do, really, I'm actually more comfortable with dealing with these in the kidney is once they're small enough, I'll actually push them back up into the kidney because I'm just right below it. If I'm in the distal ureter, I'm going to break it up and then you can basket out all the pieces. But even at this sort of lowish rate, you can see that it's very, very nice and still very effective. Even at 8 watts, 4 watts, so 0.4 and 20 is really quite effective. And lasering, taking the respiration into account. So I'm sort of staying here knowing that the stone will start to come towards me. So what I'll do here is just stay here, wait for it to kind of come towards me, and then activate the laser. And I'll bring up the laser fiber a little bit more. So I just want it a little bit faster because this is quite a big stone here, as you can see. So this is the, again, this is more thulium fiber. Let's go to some Moses cases now. That's still thulium fiber. So this is holmium YAG versus thulium fiber. So this is the case where it's a very hard stone, 1100 Hounsfield units. You can see it's upper pole partial staghorn calculus. I start off with thulium fiber. One of the things I notice is that, see, I can't quite get directly on the stone. It's around the corner a little bit and down in this sort of this upper pole calyx, but it's dependent a little bit. Because the thulium fiber doesn't have that high peak power, the one that would make the stones jump around, this is what makes the thulium fiber lasers so good at dusting because things don't move. But I want this one to move. I want to break it up into pieces. I want to get it out of there because my scope can't reach into there. So, I'm doing this as much as I can at 0.6 and 30. And all you'll see is I'll basically shave off the top here. And I can't get down into the bottom part here. So I really, can't get in there, and it's very difficult. So it's just not coming. It's really difficult. I can't angle it. I feel like we're really starting to slow down during the case. So what we did was we actually pulled out the holmium YAG, and this is my 30-watt laser. And I set it to 1 in 10. I only use 10. Now look at it. The pieces are breaking up into fragments. They're flying out, which is what I originally hated about this laser, that you had to balance it between breaking up the stone but not having it fly out too much. And I'm causing bleeding too, which I didn't with the thulium fiber, because even as you guys know, if you touch the tissue, it will not bleed. But I'm breaking up into fragments, getting it out of that calyx into places where I can reach it. And then maybe now I could even put a basket in, go around the corner and pull these pieces out and put it inside of another calyx. And I prefer to put it inside of a calyx rather than inside of the renal pelvis. The renal pelvis is too big to pop dust. You need a small area that you can get that flow moving around so the pop dusting will work better. The renal pelvis is just too big to create that whole turbulence and that outflow. So you can see here, we're just trying to move it all around here. We're using the holmium YAG. And then what we end up doing is we end up putting in the thulium fiber and just pop dusting the rest. So I think now that I've used thulium fiber a lot for the last 2 to 3 years, I've now gone back and sort of said, I think you need the thulium fiber as well too. But Moses is also very good. And Moses is really quite good for dusting as well too. But in terms of soft tissue, TFL, I think, is definitely going to be superior for that. So we had a lot of help with our bench studies that we were doing there, and I just want to thank you again for this invitation. And I really, actually, if you can, if I don't know if there's a place where you guys can chat or ask questions, I'd
Yes.
really love to hear your experience with thulium fiber laser, and what settings you've been using and how you use it, and also what type of single-use scopes you use in India.
Thank you. Thank you for your excellent talk, sir. So there is one query from the audience. They've asked, where is the pressure sensor that you are measuring the pressures with the scope? Where exactly is the pressure sensor, and how do you do that?
Yeah, good question. So that is inside, right at the tip of the ureteroscope, right where the chip would be. So and then you see it on the interface of the ureteroscope, of the interface, and I'll just show you that right here. So, for instance, if you look right here, and I'll just show you, when you look when you look right here, this is where the pressure is inside the kidney, and
Oh,
um, it takes 4 readings a second, but it'll display the average of those 4 seconds right there at 109 millimeters mercury. And then this whole thing right here is your last minute. So this is the last 60 seconds of what your pressure has been. But also on the console, it'll actually record it onto a Excel file. So you can actually then go through and look and see what your pressures were for the entire time.
okay, sir.
Good question.
Do you have any kind of temperature measuring sensor for this?
So that's the next thing. That's the next thing we're going to work on. I think that's proven to be important, and I think now too that we know with these new lasers, with how there has been some reports of some kidney damage. That temperature, I think, is our next frontier. Absolutely, but currently there is no ureteroscope that has a temperature sensor on it. But we're working on it with Boston Scientific for the next version.
Have you experienced any cases of infundibular stenosis or a PUJ stenosis or a ureteral stricture with the TFL or Homium for that matter?
Yeah, unfortunately, I have, and I've had one case, and my partner's had one case, and that is what has prompted us to go down from the 45 and 36 watts down to the 20-watt sort of ceiling, and using it over 20 watts, and I use it at 30 sometimes now, very, very carefully. Cold irrigation, definitely using a ureteral access sheath so the flow can come out, and pausing on the ureteroscope, on the laser. So those are the 3 things. So by pausing, I mean going 15 seconds, 20 seconds maximum, and then pausing for a few seconds to let your irrigation cool that down. I think when you continue on and just keep that pedal pushed for several minutes at a time, that really boils up that irrigation. I mean, I think we've all felt that. Sometimes when you have fluid coming out of the access sheath, especially if you have warm irrigation hanging up and it comes out under your hand, it gets quite hot.
Yes, sir, we
And
could feel
if it
it.
gets above that magic 43 degrees Celsius, you can really, I think, damage a kidney.
Burning
So
smell
we've
also
seen some of that.
scares us. That smell also
Sorry, say again.
smell also
Yes.
sometimes scares us. Yeah.
Yes,
Water
exactly.
feels hot.
Exactly.
Even in the gloved finger, the water feels hot.
Yes, absolutely. So if I feel that, so now we only use room temperature irrigation. I'm even thinking for some of the bigger stones, we should actually use cooled, like irrigation from the cooler, maybe, and
Does it
cool it
affect
down to.
the laser efficiency, sir? The cold saline, does it affect the laser?
Oh, I don't think so. I'm not physically tested that or done it on a bench study, but I don't see anything inside the clinically. I don't sense that.
Okay, sir. So, you do all the cases under general anesthesia, or you prefer spinal anesthesia, sir? For this dusting specifically, spinal is little difficult to concentrate on the stone for a longer time for dusting. Do you prefer? What is
Hmm.
your preference, sir?
I do most of mine with general anesthetic, without paralysis. So they just have a laryngeal mask airway in. They're not paralyzed and they don't need an endotracheal tube. So that's what I use. But my colleague Naeem Bojani in Montreal does all of his under spinal.
Spinal.
Yeah. How about you? What is it mostly in India?
Mostly we do under general anesthesia, so that we could control the respiratory rate and the depth for us to focus more on the stone. And now we are starting to do under spinal anesthesia also, but we feel little difficult to control when we tell the patient to hold the breath or shallow breathing, the patient becomes more anxious and he is doing hyperventilation. So
That's a good idea. I never thought of that. You could get them to hold their breath. That's a great idea.
we ask our anesthetist to talk to the patient, and we sometimes show the video also how the kidney moves and all these things, but it makes the patient little
Smart.
anxious and hyperventilate also. We are comfortable with the GA, general anesthesia, but we do under spinal anesthesia also for some patients. So
Gotcha.
for the lower pole stones, what is your technique, sir? Do you prefer dusting, or now with the TFL you do fragmentation and pop dusting kind of thing?
If so, I kind of look at the angle and go with what the studies say. If it's 90 degrees or greater, or just over 90 degrees, maybe 100, 110, I can laser it in situ because it has a fairly good clearance rate. But
Yes.
if it's really one of these, I think it's better to basket it out if you can, and then move it into an upper pole calyx. It's easier to get to, it's easier to control your scope, and I think the stone free rate is higher because the pieces will fall out better. But sometimes a stone is too big, and then you have to fragment it and then move the pieces out. I know it takes a little bit more time, but I think it's a bit better. Sometimes I'm too lazy and I just do it in the lower part, but I don't think it clears as better as much as if you move it. Do you tend to move it as well too?
Yes, sir. Mostly if it is basketable, and we do the basketing. Otherwise, we do
Yeah.
in situ. And with the thulium fiber laser, we go for the fragmentation settings we have in photonics machine. This fragmentation setting, where we set 2 joules and 10 hertz, so that the pieces become fragments, as you told with the Homium laser. Similar kind of effect is now happening with
Oh,
TFL laser. We do with
okay.
110 setting, or a 210 or 215 kind of settings, so that
Oh,
it's becoming
interesting.
practice.
Interesting. Very interesting.
And even the dusting, now first initially we were doing with the 0.2 and 60 watts, 60 hertz setting. And we found that focusing the stone for a long time is becoming difficult. We have to stay right on the stone for dusting to happen.
Yeah.
And
Yeah.
this is also very small, very fine dust that takes a little bit of time. Now what we are
Yeah.
doing is we are going to the fragmentation mode, and
Okay.
keeping a setting of 1 joule and 10 hertz. And similar
Okay.
kind of dusting, what we see in Homium is happening here. Little bit
That's fantastic.
little bit faster, little chipping is happening in the edges, and we are able to finish do pop dusting also with those settings. So we are now
Terrific.
totally avoiding that dusting setting, 0.2, 0.3, and a 50, 60, 100 hertz. Those things we are now not using it. Instead, we are going to the fragmentation setting and using that for dusting and also for pop dusting. Both are
That's
happening.
terrific.
That is what we are now following, sir. And
Great.
we are feeling comfortable with that setting. Do you have any experience of using suction in RIRS, sir? Like a
No. I have you tried using those access sheaths with suction?
no, we have tried in 1 or 2 cases, but we are
Yeah.
not regularly using it. Have you
Yeah.
felt any
So I have not used it yet, but I've just heard from colleagues that it will probably just decrease the pressure because you're constantly moving stuff out and keeping the temperature down, which is good. But it really the pieces may not be small enough, or it's very difficult to actually suction the actual pieces out. People have told me that it's very good for mini PCNL, that
Mm.
it's really quite good for mini PCNL, but for ureteroscopy, because it's so long and smaller, that I don't know if it's smaller or not, but is not as effective as for mini PCNL.
Okay, sir.
But I think that would be very good, interesting to learn about for pressure.
Yes, sir.
I want to
So,
show you one video. This
yes,
is an encrusted stent, just to show you the difference between the Moses and the non-Moses. So you can see Moses here will make very, very small pieces of dust and very fine pieces, Whereas when you turn off the Moses, it's like the old Helium egg, you'll see large chunks blowing off of here. It's the same patient, and we're just turning the Moses on and off here. So this is just a really good display of the difference between Moses and non-Moses. It's just much finer dusting with Moses and more fragmentation with the non-Moses, which essentially is what we've all been used to, which is the old traditional Helium YAG. But
Yes.
I just kind of wanted to show you this video.
Nice, sir. Nice. Okay. So, do you find any role of diuretics or furosemide to reduce the this backflow, pylovenous backflow or pylotubular
Huh.
backflow? Anything?
I've never actually thought about that. Have you guys used that, or has there been studies
We
on that? I've never
regularly
used
use
that.
that. Whenever lasing time first time is crossing 20 minutes or 30 minutes, we give a 20 mg of Lasix to just, but we
What a
find that
terrific idea.
sometimes the sepsis rate is little better. We don't know, we don't have the proof for that, but we generally use in our practice.
Yeah,
Yes,
that's a terrific idea. I love it. That's great. That's very cool.
and it also reduces the need for this irrigation also. We use gravity irrigation.
Right.
If you do a Lasix also, that also produces a lot of urine, and this also can be reduced a little bit. So,
Right.
what is your
That's
regular
great.
irrigation method, sir? Gravity or handheld manual syringe pump or something? What do you use regularly?
So I'll normally use a pressure bag at about 150 millimeters of mercury. But if it's getting harder to see, then I will use a hand irrigation, just a syringe with a three-way stopcock. And
No.
then what I do is I basically just go in and just kind of do it as much as I need to see. When I'm using LithoVue Elite, I'm then able to detect my pressure, and if the pressure gets too high, I'll actually slow down how much I'm irrigating with my hand. Actually,
So you
what
always
types of irrigation do you use?
we use a hand syringe, 50 ml syringe with a three-way stop.
Yeah, that's what I would use too, and you can really control your pressures with that, just enough so that you can
The
see.
trained technician, they can actually help us to in flushing. Sometimes when we need flush, they can flush. Otherwise, they can slow the irrigation down. So the trained technician we are having. So they are doing with the handheld syringes.
Gotcha, great.
So, so nice talking to you, sir. It's been a great discussion. You have shared your thoughts. It's very helpful for us, and it has motivated us to do more research in this aspect also. So we'd like to associate with you for any further programs or any kind of research work.
Terrific.
We would be loving to do that. Thank you for your time, and thank you. And thank you once again, sir.
Have a good evening. Thank you so much for the invitation again. It's been my pleasure.
Thank you, sir. Thank you.
All right. Bye-bye.
Bye, sir.